I'm going to have you share the agenda because I have frozen again. I apologize on my screen. So good morning, everyone. This is Hina Shah. I'm a senior analyst at the Kansas Health Institute, and I will be facilitating this morning's meeting. You are the Access to Services Working Group that was convened by the Senior Care Task Force. This is meeting number 6 for you, and you are talking about adult day services today. We have a pretty jam-packed agenda today, so I do want to get us started. I'm going to start us out, and I apologize because my screen is frozen right now, but I'm going to cue in, and Emma's sharing the agenda, hopefully. But we're going to start out this morning with introductions, and then we will have topic discussions from several different speakers. You were sent some materials earlier this week and also materials this morning. If time permits, we will start doing your recommendations today, but if it doesn't, then we will wait for the next meeting. And with that, I'm going to start and kind of call on you for introductions. And as you say it, I want you to think about kind of the one word that comes to mind when you think about senior day services and really what you want the working group members to really keep in mind. So I'm going to start with Dan Goodman. Oh, and he may not be on yet. And oh, there he is. Hi, Dan. Do you mind introducing yourself and sharing one word about kind of, I have access again. One word about, senior day services and kind of what you want the working group to keep top of mind?
My name is Dan Goodman. I'm the Assistant Commissioner of Long-Term Supports and Services for KDADS. One word. Opportunity, maybe? Opportunity.
Great, thank you. All right, next I'm going to call on Annette.
Annette Graham, Kansas Association of Area Agencies on Aging. Progress.
Thank you. Jan?
Jan Kimbrell, Kansas Silver-Haired Legislature, Morris County. Needed more, 2 words.
Jamie?
Get in with Alzheimer's Association. I would say it's kind of like 2 words actually, but rural access.
Rural access. Sarah?
Sarah Schlutter, Johnson County Developmental Services. I would say flexibility in service delivery. Flexibility.
Thank you. Tanya?
Good morning. I'm Tanya Dorf-Bruner with Oral Health Kansas. I'm also doing the 2 words, ensuring dignity.
Thank you. Do I see Stacy?
Yes, hi, Stacy Carson, Johnson County Developmental Supports, and my word is collaboration.
Thank you. Heather Brown?
Hello, Heather Brown, Johnson County Developmental Supports, and I would say engagement.
Thank you. And then do I see Linda?
I'm here, Linda Mowbray, Kansas Healthcare Association, Kansas Center for Assisted Living. My word is transportation.
Yeah. Sean?
My name is Sean Sullivan, Midland Care Innovation.
Thank you. And then just a reminder of your meeting commitments, come ready to discuss and compromise. You want to keep your remarks succinct and on topic. You want to not hesitate to ask clarifying questions as you hear from all of these experts today. I will make sure you start and end on time. And please, when you ask a question, identify yourself, as we do have viewers watching in on YouTube or on Harmony. And so please make sure you identify yourselves. And then remember your vision statement: establish and expand a clear path with public policy recommendations for Kansas older adults and caregivers to access services. Have I missed any working group members?
Heather Tice with Cottonwood Incorporated.
Thank you, Heather. You are a supplemental expert today, so I will call on you afterwards, but thank you so
perfect.
much. Yeah.
Thank you.
This is Eileen Doran, and I am with TARC, and I am subbing for Shelby Fry.
Thank you. Again, another supplemental expert. Anyone that's actually on the working group? Have I missed anyone? All right, terrific. Then let's dive in right away with our subject matter presentations. I'm going to stop sharing here. And I want to start off right away. Do we have Julie online? I know she had another commitment, so she needed to get on first. All right, well, if Julie is not available, let's hear from our IDD providers first. And so Heather, would you like to go first from Cottonwood? How about you introduce yourself? If you do have a word that comes to mind, you're welcome to say it, or you can go forward with your comments about the services offered at your organization.
My name is Heather Tice, and I work at Cottonwood Incorporated, and I am the director of our life enrichment services. And one of those enrichment services is our retirement program. So I'm really just wanting to be a part of the conversation and make sure that our population is being included in all of the processes to find the best services possible for all older adults, and that would include the folks with intellectual and developmental disabilities. And I guess my keyword is inclusion. What else did you need me to say?
Just anything else about kind of the population you serve and the different services, maybe anything that changed with the pandemic even?
Oh, sure. Okay. So with the pandemic, our folks are very, they're high risk, very high risk. And so we actually stopped our day services, and everybody was staying home for quite a bit of the initial pandemic. We were all like in we were in place, and everybody was in their own homes. So our day services were shut down for quite a bit. And but really our goal is to get out in the community and do things. So it was a different kind of day for them, because they weren't at our center. They weren't working. They weren't doing community jobs. Some of our folks are not fully retired. They kind of do a whole bunch of different things, but part of it is retirement. So I don't know if that maybe explains a little bit, but our services, we do community employment, work center employment, and retirement. And my other department is work enrichment, which is sort of a hybrid of work and activities. So, and I would say our folks are very active for the most part. And so the pandemic made a huge impact on their activity level, as far as going into the community, going to pick out what they want for snacks or dinner, or like going to the movies or whatever, just like everybody else. I mean, it was very impactful for their activity level in the community.
Thank you. And then who is the TARC representative today in for Shelby Fry?
Eileen Doran.
Hi, Eileen. Would you like to also share your comments and then I can open it up for questions?
Yes, you know, I think that one of the reasons that we were happy to be included is because the traditional service model that applies to or is available to most individuals with intellectual and developmental disabilities does not necessarily adequately meet the changing needs of our population as they age. We provide some specialized services to not so much seniors as we do folks with intellectual disabilities who also have dementia. And trying to meet those needs in a traditional day services program has sometimes been challenging, right? So we have competing goals sometimes and requirements. Just like Cottonwood, our services are to be out in the community. That's the whole basis of what is the funding for our day services program. But we find that just like anybody else, when you're either 70 years old or you have dementia, being out in the community is not necessarily what's either in your best interest or what you are interested in doing anymore. And so we're really sometimes challenged to meet the needs of our older adults, especially as they develop early signs of dementia, which is very common with our individuals who have Down syndrome. So we are still, you know, changing things up on a regular basis at TARC as we have, you know, as I said, established sort of a specialized program for those folks and created space that is able to better meet their needs, the needs for more routine, the needs for a little bit more quiet, etc. So we're just interested that we were able to be included in this conversation today.
Thank you. Working group members, any questions? And please be sure to identify yourself. And you can also post them in chat.
Jan Kimbrell.
Go ahead, Jan.
I was wondering, do you have a number of clients that you're serving, and is there a population still that is being unserved at this present time that need the services? Do you have any kind of a estimate on how many people are using your services at this time, and what you see is the need for as the numbers increase or decrease? Do we know and where everybody's located? I mean, you're apparently Topeka, and then I don't know where Cottonwood is, but maybe that's in Topeka also. I have no idea what our need is in the area and I live in. So I didn't know if there was a report that would tell us that. Or
well, this is Eileen. I can just speak. The Shawnee County CDDO does track all individuals with IDD in the community. So we do have the ability to identify by age, of course, what that population is. But then we also have the anecdotal information as each individual is in services, whether or not they're having challenges on having their needs being met by their regular or traditional, I should say, day service or residential provider. You know, we've had folks who, yeah, they have terminal illness. They have, you know, I mean, it's just, and we expect our residential providers to continue to serve them because that's their only alternative right now, other than long-term nursing care. So we're just doing our best to try to see what changes can be made within our system to recognize the changing needs of our population.
Okay, thank you.
This is Heather Tice from Cottonwood Incorporated, and we're in Douglas County in Lawrence. And we also have a CDDO that tracks all of the information as far as age, population, who's still waiting in services. There is a large waiting list for our IDD services. I think it's a 10-year wait. So you graduate from high school and then it's 10 years later that you can get services. So.
Okay.
I think I would just add also that one of the challenges is that sometimes folks don't even enter services until they're much, much older because they've lived at home with family members. And so those family members pass away or themselves end up in long-term care, and we suddenly are in a crisis situation with folks.
Thank you for mentioning that. This is Heather Tice again. Thank you for mentioning that. It's true. The crisis is pretty much one of the only ways to get in and bypass the waiting list, but it is a rigorous and usually pretty dire situation in order to get services without waiting the 10 years.
Thank you. Linda Mowbray, did you have a question?
I do, thank you. Linda Mowbray, Kansas Healthcare Association. For both Cottonwood and for TARC, as your residents age, whether they are IDD or whatever waiver service they do happen to be on, what are the barriers in finding and accessing the more senior or geriatric services? And is there a resistance to switch waivers, or are there reasons to not switch waivers? Thank you.
I don't know who wants to go. Heather, did you want to go first, or would you like me to take it?
You go first.
Okay. There are lots of challenges. One is that the waiver isn't necessarily something that they can just switch. I think there's a hesitation on the part of family members to risk, because of the waiting list and how long it took some of these folks to get on that waiver to begin with, to leave the waiver and go to a different waiver and then find that maybe that waiver is not meeting all of their needs. I know that we've sometimes encouraged individuals to look to the PACE program as an alternative for them, but they're hesitant because they don't want to give up their long-time healthcare provider, because again, I think, and I'm not trying to say that our individuals are so different than the typical population, but change is harder for folks with IDD, right? So, and it's hard to find medical professionals who really understand some of the challenges, communication challenges, or specialized medical needs that they have. And once you find that, it's really, there's a lot of reluctance to giving that up. And then also just like anybody else, you know, if you've lived for 30 years with a couple of roommates in a group home, that's your home, right? And so just like we have folks in the community, elderly folks who don't want to leave their home and don't want to have to move somewhere else, there's a hesitancy to, and getting those services within their group home or their traditional residential provider is not necessarily possible. Hospice services certainly are different, but supplemental services are not always possible.
Thank you. And Annette, did you have a question?
Yes, thank you. Annette Graham, Kansas Association of Area Agencies on Aging. And you might have already covered this. I had some internet issues, so I missed part of that. I missed the presentation. But with our focus on age 60 and older, I was just, do you have information and data on the numbers of individuals 60 and older that are on these waiting lists?
So not necessarily, I mean, we would know if any of them are on the waiting list. We certainly know all the individuals in each of our counties who are over 60 who have already been identified. So we continue to pull people in regularly who have just either moved into the community, you know, because maybe their family members have moved here later in their lives, and suddenly they're on our radar screen when they never were before. But we certainly know which individuals are on the waiting list and by age. So that's certainly data that we have available to us.
So thank you. So that would be data you could make available to the task force about the numbers of.
Yes.
Right. Okay, thank you.
This is Heather Tice at Cottonwood Incorporated in Lawrence. We could also do that also. And for our folks that are interested in retiring or accessing other services, you know, that we follow their choice as much as we can. But I would say the just to answer the question of why they would be hesitant to go into aging waiver versus IDD waiver, I think it was pretty much answered before. But for our folks also, that it is a real I'm not sure how to say it, but it's a real interesting predicament when you're diagnosed with dementia, that actually becomes your number one disability versus ID. I'm not sure if I'm making it clear, but if you're diagnosed with dementia, then that actually is more of your diagnosis than the IDD at that point. But as you know, we are serving them, we know them, we are working to make them as comfortable and as happy as possible. So and like moving them to someplace else would be very traumatic at some point. But at some point, you know, there is a place and a time when moving to a nursing home, it may be the best choice for them. So.
Thank you. Maybe one more question, Linda, and then we'll go to our next speaker.
So this is Linda Mowbray, Kansas Healthcare Association. What do dementia care specialists, whether they're in the nursing home or whether they're working through the Alzheimer's Association or with assisted living, what different training or what do we need to know specifically about the IDD population and perhaps differences or similarities with their dementia experience and the approach that we might take with them?
This is Eileen, and I guess what I would say is that so my father-in-law passed away recently and he had dementia, right? So he lived with us for 15 years. So I watched that process with him. I've also had the experience of watching that process with our individuals and services. And I think it goes to what Heather was saying, which is, you know, having a good knowledge of what that person's history is critical in both populations, right? And I think that some of the challenges are that many of our individuals don't have, because of their IDD, great communication skills. And so their ability then, once the dementia occurs, is either a further impairment of that. But having people who understand what that communication looked like, how to communicate, how to keep things on very, very basic levels at times, how to break things down into small steps when you're trying to teach somebody. Those are all things that we have already been doing with our population on a day-to-day basis, and really understanding how an individual learns differently when presented with a new task to learn. And then also, so many of our folks also have issues with respect to, the inability to ambulate, or they may already have needs for assistance with toileting, etc. So it isn't so much of a loss of some of those skills, it's just a further inability to communicate about those daily living tasks that they already required additional assistance for: feeding, toileting, dressing, etc. And then the dementia on top of that just further complicates it.
This is Heather Tice. I agree. And I think really the change in someone experiencing dementia, what we found, at least in our experiences, often folks with IDD end up with a shorter experience because it moves quickly through their bodies and their brain. So what one person that doesn't have IDD might experience dementia for 15 years, someone with IDD might experience it for 5 and then pass away, if that makes sense.
Thank you both for your comments, and I hope that you can stay on for the remainder of the meeting in case other questions arise. And then those who weren't able to ask a question, please send them in chat, and we can always send them also to these two providers. Thank you so much. I'm going to turn now to Julie Walter from North Central Flint Hills Area Agency on Aging, if she can provide some comments on kind of senior services provided at AAAs, especially in her area. Any policy implications, if she's aware of any senior centers that are concurrently being used as adult day centers, is another question that has come up in this working group as well. So Julie, if you could introduce yourself and provide some comments to the group. We don't hear you. Hold on. There you are.
You hear me? All
Yes.
right. Can you hear me now? All right, great. Good morning, everyone. Thanks for the opportunity to visit with you, and also I want to let you know your work on the Senior Care Task Force is very much appreciated by our agency. I'm Julie Govert-Walter, the Executive Director of the North Central Flint Hills Area Agency on Aging. Our agency is one of 11 area agencies on aging in the state. We serve an 18-county region. We're based in Manhattan, and we have offices in Emporia and Salina as well. Our mission as an area agency on aging is to provide a comprehensive and coordinated array of community-based services to meet the needs of older Kansans and caregivers in our respective region. We also serve as one of the 11 aging and disability resource centers in the state. And this means that we are clearinghouse for information and resources and referrals to people that have disabilities, and also families, caregivers, loved ones who have a person in their lives who is living with a disability. I have to also let you know that besides my work at the Area Agency on Aging, I'm also a caregiver for my dad, who's going to be 95 on July 4th, who does have some dementia issues. So I'm sort of living the dream along with many other caregivers in the state. In fact, that's where I am today, and I appreciate the flexibility to be able to be with all of you today. So I just wanted to sort of give you an overview of our agency in terms of what we have learned. We back last year, we did a needs assessment, and we did a specific needs assessment sent to caregivers in our region. We have a newsletter that goes to around 2,500 people called Caregiver Assistance News. And we sent a survey of people on that list to find out what those caregivers on that list felt were the basic needs that they were having as caregivers. The top 5 issues mentioned in the survey included help with exercise, falls and fall prevention, help with memory difficulty, nursing home care, and in-home care. The people that answered the survey, 75% of them lived either outside a city or town. They lived either in a small town or in a rural place. So we're talking about a lot of rural people here. Adult day services was not listed as a top need in the survey. As I told you, it actually was number 10 on the list. But I think, I'm going to tell you, I think that's because a lot of people in Kansas and particularly in rural areas don't know about the possibility of adult day services. They don't know what it is. They haven't ever, quote unquote, seen it. So, you know, they wouldn't necessarily say it's a need because they don't know that it's a service that could exist in their community. The availability of adult day services in our region is somewhat limited. I will say that, we have adult day services in Salina and one in Emporia. These are services available to families and caregivers. People can get signed up and their loved one can be at an adult day service place throughout the day. However, and these are great options, but there's only 2 and they're in the larger cities. So those caregivers who are living in a rural location are not available. They're basically, they don't have access to these services in any meaningful way. My definition of an adult day service, the ideal one anyway, would be a safe, accessible location where older Kansans that have essentially low-level needs can hang out and enjoy socialization and activities during a regular workday. So I think that, I mean, that's basically what our definition is right now. We haven't essentially adopted it, and I don't know what the other rules say, but that's how we look at adult day services in our region. And that would be for if we could have the opportunity to develop adult day services in some of our senior centers. And I have to say that, again, I'm a caregiver that's serving, that has a loved one who's in a rural place. And basically, you know, trying to find a place where, hold on a minute. Basically trying to find a place that would be a happy place for dad to go to on a day when, let's say, I have to be somewhere else, or it's just, there's a need for respite. Having that location would be a great help. And I know that I'm not speaking just for myself. I'm sure there's a lot of other people out there. However, in rural places, you're not going to have a lot of people. It's going to be a few people, maybe on an intermittent basis. So that poses some other challenges. For example, if I were a company that's trying to make a profit off of this service, probably this kind of service is not going to be very lucrative. So another model probably needs to be explored. And my basic thinking, and this is only thinking right now, is that senior centers are already part of many of our rural communities. They are, of course, located in rural places. They are considered volunteer hubs or hubs for volunteers in their locations through friendship meals and other volunteer activities. Senior centers do have some staff capacity already, and these staff capacities could be expanded. And senior centers are not quote unquote medicalized, meaning they are in the community. They're not institutions. There's not, there's not a feeling like, oh, if you go there, you'll have to be there for the long term. It's a community-based service that people can come and go. And senior centers, there would be or could be an opportunity for senior centers to rethink their roles in our communities. For example, some of our senior centers are challenged with funding for other things that they could do or be doing. And perhaps this would create an additional funding stream, probably not a big one, but an additional funding stream that would also meet the needs of their community. But again, as I told you, all of these are great ideas, but we don't really have much of this happening in our particular region right now. And I'm happy to let Michelle Morgan, who's also on this call, to chime in, because Michelle and I have talked a little bit about some of the things that she sees in her area. Michelle, do you want to say anything at this point?
Sure. Thank you for giving me some time, and I'm glad you are talking about caregiving. And I'm sure you all have heard this quote before from Rosalind Carter, but she says there are only 4 kinds of people in the world: those who have been caregivers, those who are caregivers, those who will be caregivers, and those who will need caregivers. And out here in Western Kansas and across the state, that statement is absolutely true. Yesterday, I came across a new report that was released from the National Alliance for Caregiving. It was called Understanding the Systematic Challenges Facing Family Caregivers. And it was very interesting because it did say collectively family caregivers spend over $500 billion a year in costs associated with providing care to their care recipients. And a large part of that simply is because we need to develop more services and help for these families. When we're talking about lack of resources out here in Western Kansas, people don't have a whole lot of choices. And in some places, respite care or in-home services are almost non-existent, or there might only be one provider. I'm kind of like Julie, and a few years ago, I was taking care of my father-in-law, trying to help my mother-in-law. He had esophageal cancer. And one of the things that I found very interesting in this report was that the percentage of caregivers of rural care recipients who have performed medical or nursing tasks was much higher than in the urban areas. And again, it really is because that type of care is not available. 62% is what they said was the percentage of rural care participants who were providing medical care or nursing tasks. So I'll tell you what, when we were going through that, we learned a lot and we got pretty good at it. And we used technology such as FaceTime. So when we had pumps that weren't working and my mother-in-law needed some help, we could help her that way, when we were 30 miles away and couldn't be there in just a few minutes. The other thing too that we've noted is that a lot of caregivers will go into debt taking care of their care recipients. This report said that over a quarter of caregivers who tend to rural care recipients have taken on more debt, such as credit cards, loans, lines of credit, borrowing money from other people, family members and friends, than caregivers who tend to urban care recipients. And a lot of times I do think that it is simply that there aren't places and services for care for mom or dad or for your aunt or uncle or whoever it might be. So you are taking on more of that burden yourself. The other thing, obviously, is that you all know with caregiving tasks, people will report poor self-reported health and they experience quite a bit of stress and they feel guilty for asking for help or for not providing the bulk of the care. And so it's not just important that we have services and supports that are developed for people who need caregiving, but also that we have it for the caregivers, because, you know, we see often too that sometimes the caregivers don't last as long as the care recipient, just because they are under so much stress that that sometimes they don't last quite as long. So, I mean, basically, if we can look at greater access to resources for support services, and when I was listening at the beginning, a few of you mentioned some words such as partnerships, collaboration, innovation. And I agree with Julie that a standalone adult daycare service probably isn't something that is sustainable. We've had a few of those here in Hayes, which Ellis County is our largest area, and we have a hospital here, and they were not able to operate as a standalone service. So I do think it is going to take some innovation and some partnerships and working together, you know, with other people so that we can perhaps, you know, find some additional adult daycare services. And, you know, and if KDADs, you know, it would be fabulous with our aging Kansans if we could have a senior advisory council for aging, you know, just specifically for KDADs to focus on some of these things. But yes, Julie, I agree wholeheartedly with every single thing that you said. We're seeing the same thing out here.
Thank you both. Questions for speakers? Jan, are you saying something?
Hi, Jan Kimbrell, silver-haired legislators. I know in our county, which is Morris County, our county provides some money to the Senior Citizens Inc. board, which then assists the two centers we have in our county. And I understand that's kind of not the norm. And I'm wondering if the counties themselves would set aside or budget or help with the centers that are in their communities to be able to expand their services to this type of thing that we're talking about. But they have to do it in conjunction with the state, which is where we are with the cooperation thing again. If that would be helpful in establishing these in the small local centers that don't get services. And I really,
I would be happy to, I'd be happy to talk about that a little bit. Actually, almost every county in our 18 county region, and Morris County happily is one of those, counties do provide some significant support for maintaining things like friendship meals, helping support the Senior Care Act, and providing a required match to the Area Agency on Aging. However, in terms of moving forward on an initiative that would, let's say, build adult day services into a local senior center operations, it would have to be very collaborative. The county, the senior center boards, there would have to be a lot of collaborative meetings, agreements, fact finding, things like that. And, you know, the Area Agency on Aging has a role in doing that. I will say that one of your questions that I saw in the email that was sent was that, does the Area Agency on Aging have dollars to do this? And I'll just be very honest. The Area Agency staff, and at least in our agency, is very stretched right now. And it's not that we couldn't do it. It's just that our staff have quite a few other things, mostly related to the aftermath of COVID. But I'm just saying that. But do I think that that county money is important? Yes. But what I think is most important in terms of moving forward in any community on this initiative is to have community, local buy-in, that this is a thing that is a need and is a desired outcome in that local senior center. love those senior center boards. They're great people. They do lots of important work. But sometimes, I'm not saying this is about Council Grove, Jan, but we see it as sort of a trend, a pattern that sometimes they're tunnel visioned and they see only what they're doing and they can't, it's hard to see what else might be able to be done. I hope that I addressed your question.
Thank you.
I think so. Thank you. Thank you.
I see Annette's hand up and then Jamie.
Annette Graham, Kansas Association of Area Agencies on Aging. Thank you, Julie and Michelle, both for your presentation. I'll just make a comment and then I have a question. And the comment is that in the field of aging for many years, and back in the late 80s, early 90s, we saw a lot more standard adult daycare models, even here in Wichita, in the urban area. Now there's very, very few, even in Wichita, that are standalone, that function as an adult daycare service provider. We see more that are kind of associated with nursing facilities and those that have some options for like respite care or short-term temporary. So I know this is a big issue. So it's an interesting concept to have senior centers play that role. Do you know of any models across the country that have that model? Or are there ways to kind of replicate an existing model of something that's working?
And I haven't done any specific research on this. I'm just going to say United States is a very big country. There's a lot of area agencies and a lot of senior centers, and I'm sure there must be some sort of model out there. But I don't have a specific one in mind. Michelle, do you know of anything?
You know, I do know that there are some that serve as multi-purpose senior centers to where they have libraries and computer labs and pharmacies and all kinds of things in there, to where it wouldn't surprise me if it would be one for, you know, high functioning people. You know, we kind of do it a little bit, not formally at all, but we do have people who, you know, a lot of our aging folks, you know, they are high risk individuals that we serve. It may not be that they need 24/7 care or all day care, but there are some of them who will ride the bus down to the senior center first thing in the morning and have coffee, and they'll stay for lunch and for the activities, and then they'll ride the bus home late in the afternoon to where they've spent most of their day there. And family members will call our manager and say, how was dad? Is he eating okay? Is he showing up okay? Is he wearing his coat? So I would say informally, it might be going on a little bit, but I do think that it is a good concept and an idea that if you could have someone trained to oversee some of these activities. But yeah, as for ones that are formally doing it, no, I'm not aware of any in the state.
Jamie?
Yes, my question is for Michelle. This is Jamie Gidding with Alzheimer's Association. You had mentioned that there was a adult day services program in Hayes that was a standalone but had trouble staying open. What would you say the main reasons for that would be?
You know, I would say they were trying to do maybe a little bit too much. They were trying to run it more like an assisted living facility. So they had a nurse who was doing meds, they had an aide, they had someone doing food, they had someone overseeing it, you know, doing activities. And the thing is that they didn't have near enough people coming in. And the other thing is that, you know, a lot of these caregivers and the care recipients didn't have a whole lot of extra spending cash. So it was kind of unaffordable when they were paying for it privately. And then also, I'm not positive, but I don't remember what the MCO reimbursement rate was for adult daycare. But long story short, there was too much overhead and the volume was not there to make it sustainable.
Thank you.
Thank you. Sean?
Morning. Thank you, Michelle and Julie. You both provided wonderful information and great personal examples of the challenges of caregiving for either of you. But Julie, you mentioned kind of the survey or the gaps that you identified through the survey that you all did. I think you both hit the nail on the head that it's hard to make adult day work as a standalone offering. That certainly has been our experience at Midland. But if it's something in addition to already being done as an add-on, then that can work. So as an example, we likely are going to go and add and relicense our 4 of our PACE centers to be able to offer adult day to non-PACE clients. When I initially started thinking about this option as a gap to help with caregiver burnout and support, I was thinking more of, can we get more nursing homes, assisted livings, clinics, hospitals that kind of do those add-ons where it's not everything they're doing, but it's an additional service with the baseline staff they already have. But Julie, you mentioned the concept of the good thing about senior centers is they're not medicalized. And I do think that is an important component of fitting the desire of people to be willing to go into adult day centers. Can you talk more about that first? And then second, can you give us maybe a better understanding of the baseline operations of what a typical senior center is, if there is one in most rural counties? So in terms of staffing versus volunteer support versus how long they're open, which then leads to the thinking through the possibility if they're going to have some sort of collaboration here, that is an important factor. So thank you.
Sure, I'd be happy to tell you. Well, the medicalization thing I think is important. It's one of those psychological things, but it's also something that I think it's real for people. If you can go to a community-based services or have your loved one go to a community-based service like a senior center where you know that somebody's sort of looking out for them, but you don't have to have a nurse there all the time or doctors all around. I mean, I'm just saying it's more of a friendly place. In our region, we call our senior centers friendship centers. And we like that term because the concept that it's friendly, your community friend should be there. So that's basically what I'll say about the medicalization concept in terms of what, the thinking that we've done, at least at this point, is that if we could upgrade somehow the staffing qualifications of our senior centers. We have some amazing senior center managers, and Sean, every one of our senior center has this position called a senior center manager. Their basic role, at least in our region, is for that person to maintain the documentation that we need for friendship meals. That's basically their role because that's where the money's coming from right now. But if we had a magic wand available, I would see that person would have some sort of higher level training. They don't need to be a registered nurse. They don't need to even be a CNA perhaps, but some sort of training where they could deal with the basic challenges if they were going to provide some oversight of an adult day service center, or if that's not possible, have somebody on as a consultant or on contract that would provide those things. As I said, we're talking, at least this discussion is focused rural places. And let me tell you what rural is. In where my dad is living, we're talking Zenda, Kansas, population 210 people. They have a senior center location there. Meals come out of that senior center, and God bless the volunteers that are delivering home delivered meals to my dad during the weekdays. But that's rural, and that's we cannot expect that senior center to magically become an adult day service center, but there's a possibility that somehow we could work with the senior center board, with the senior center manager, and get what could be done so that people like my dad and others in the community might be able to go there and have a respite for the caregivers, or just have a day out for people to enjoy socialization. And let me also say that that senior center in Zenda, Kansas is probably open from about 9 o'clock in the morning till 1 o'clock in the afternoon. That's it. Now, again, if I had my magic wand, I'd say let's have that be a flay of service when such services are needed. That would also mean people, workers, or whoever is going to have the staff is going to probably need to have some basis in PRN, meaning they're not going to have people every day of the week, probably, but on some days they're going to need some extra help. And so that's a whole nother thing to think about. I will say, Sean, all of our senior centers have senior center managers. Some of them are working only 2 hours a day because that's all Friendship Meals budgets can afford. And there may not even be serving that many meals in that community, but those meals that are served are important. So but you need 2 hours of time. Some of the locations also are doing cooking responsibilities. And of course, there's more staff in those larger centers that are serving more meals. A lot of our senior centers are open essentially from 9 a.m. to 1 p.m. Again, why? Because that's our major focus is on Friendship Meals. Some senior centers stay open longer because they are paid with county money, and those additional hours are paid from county funds. Does that answer your question, Sean?
It does. Thank you. I appreciate the overview.
Thank you. And Dan, did you
Sure.
still have a question?
No, I think she touched everything. So,
Great. Dan Goodman, sorry.
oh, sorry.
No, I think that Sean and Annette addressed some of those things I was going to say. So, and Julie.
Perfect. Well, thank you both for your comments and your time and answering questions. If there's any further questions from the working group, I will be sure to send them to you. Next, I'm going to ask Colleen Marshall.
Tina, Tina, I just want to tell you that I can send, wrote some specifics, recommendations up if the group is interested. I do want to say and reiterate what Michelle said. Establishing, if it's not already establishing, or strengthening the state advisory council is very important as we talk about initiatives like this. And that's the advisory council from KDAD. So I just want to chime in and say that there's some other recommendations that I'd be happy to put in writing and send to whoever would like to have it.
That'd be terrific, Julie. Thank you. And if you have a chance to put them into chat, I can share them as well when they're developing recommendations. So thank you. All right. Well, I'm going to call Colleen Marshall then. Would you like to share your screen for your presentation, or would you like to do it for me? Would you like me to?
If you could do it, that would be great.
Okay.
I want to thank you guys for allowing us to have a little time with you today. My name's Colleen. I am with Adult Day Services at Catholic Charities. We are been serving the community since 1975. We service those with IDD. We are rooted in serving the seniors. We have the affordable programs. We recently moved to a new area that has lots of acreage, lots of opportunity and growth for us. So we're very excited to be in our new community. We service those that have dementia, Alzheimer's, and loneliness. So we serve our seniors that may not have that specific diagnosis of dementia or Alzheimer's. It could just be loneliness, depression, isolation. And then we also service the adults with developmental or intellectual disabilities, autism, ADHD, cerebral palsy, Down syndrome, just to name some of the basic touches of those. Our big thing is socialization and connectivity. Our day program serves seniors and provides them the opportunity to maintain physical and social health. So we serve IDD program 18 and older. Our senior program is 55 and older. We provide group and individual activities. We do community outings into the community. Again, we are licensed by KDADS, and so we work off of all those needs. We provide meals twice a day, breakfast, lunch, and snacks. We also have a nurse on staff that provides medication. She's an RN. She's here all hours of the day, as well as all of our classroom lead staff or CNAs or CMAs. So we do have licensed staff in all of our rooms. We do have our new campus. We used to be over at Central and 235 here in Wichita. We are now out at 96 in Meridian. So our building used to be the police training station here in Wichita. We have 5.5 acres. We have 10 program rooms. Our old building used to have 6 compliant bathrooms. Now we have 24 ADA compliant bathrooms. We have an interior courtyard, and we are newly developing, and will be open this spring, a new area for our outdoor campus. And that outdoor campus is going to have a water pad, canopy, picnic area, percussion, and tactile. So where you're seeing the greenery, that is turf to where walkers and wheelchairs can easily maneuver onto that turf, as well as the entire outdoor area will be encompassed by a wide concrete walking path, and it'll all be fenced in for secure and safety. Obviously, I didn't put a lot of pictures in it because while pictures may be worth 1,000 words, seeing adult day services with your own eyes is really the best reality and experience to our community and campus. So if you're in the area or ever hit the Wichita area, we'd love for you to give me a call, come by and see us. My phone numbers are listed. Again, we do serve those that need financial funding. We offer a sliding scale as well as private pay for our services.
Thank you. Any questions?
Heather Brown, Johnson County Developmental Supports. Just to clarify, do you provide your day services just for adults with IDD, or are you also serving the general population?
We serve IDD as well as seniors with dementia and Alzheimer's. 18 and over for the IDD, 55 and over for the senior program.
Any other questions? All right, well, thank you for your time. Annette, sorry, I didn't see your hand raised.
Okay, Annette Graham, Kansas Association of Area Agencies on Aging. Can you just kind of describe how you're funded and what billing options there are? I know you said you serve the private, you also are privately fee, but what other funding sources do you have?
We have veterans assistance, we have Medicaid, so we do the HCBS waiver, and then sliding scale fee, as well as private pay.
Any other questions? Well, thank you so much for your time. All right, well, our next 3 speakers are from the managed care organizations. We have Melody Dowling from United Healthcare, Jennifer Parente from Aetna, and I think I saw Nan or Stephanie. Nan Perrin again from Sunflower Health Foundation. And so I'm going to ask all 3 of them to speak first and then open up for questions if everyone's comfortable with that. And so with that, Melody, do you want to introduce yourself, and would you like me to share your presentation, or would you like to share the screen?
Yeah, I'll try to share my screen, and if that doesn't work, then I'll ask for your help. My name is Melody Dowling, and I'm the Health Services Director at United Healthcare, the Kansas Medicaid plan. share my screen.
Xavier, would you mind making her a presenter?
All right, can you see my presentation? Yes? Okay. The MCOs were asked to talk about community transitions and the impact from COVID, from the pandemic, and if there's been a kind of a change in the model since then and what that might look like going forward. So I'll talk a little bit about our community transition program at United Healthcare. And we have care coordinators assigned to each nursing facility across the state. And part of their process is to meet with the individuals on at least an annual basis to discuss their interest in transitioning to the community using our assessment process. It's a comprehensive assessment that looks at their goals, their needs, any barriers that they might have for transition. And if someone is interested in transition, we then work with our transition care coordinators. We have 5 dedicated coordinators that work solely on the transition process. And they worked in collaboration with the assigned CC to plan a comprehensive transition plan for that member, which could include all kinds of things: housing, setup, their HCBS services, community supports. And then we engage the providers in that person-centered planning process. And throughout the pandemic, we've had to partner with our providers to help us with that transition process. And some of that includes going and actually helping to set up the apartment and get that member transitioned into the community. And once they have transitioned into their new living situation, then we continue to monitor them, and they're enrolled in our long-term care HCBS care coordination process, where they receive regular touch points, person-centered planning meetings, and reassessments. So some of the impact that we had from the pandemic is in 2020, we saw a pretty significant increase in the number of members who transitioned from a nursing facility out into the community. It was a 16% increase in 2020. And we know that there was a lot going on in 2020, a lot of cases, a lot of deaths happening, a lot of fear, and families often elected to take their loved one home. And sometimes the family's providing the care, sometimes others are providing the care, but a pretty significant increase in folks leaving the nursing facility in 2020. It's interesting, though, that then in 2021, it went with that same increase was then a decrease from 2020. We're back to kind of our baseline of where we are typically at with transitions in 2021. Challenges for community placement that we continue to see is the COVID visit restriction. So we're still not really in the nursing facilities face to face. So while we are still doing assessments and utilizing technology to do that as virtually as we can, and cooperating with the facility and the guardian and providers, it's still not quite the same as actually being able to meet with that member face to face and do our comprehensive assessment. Other challenges that we've heard a lot about is the workforce shortages, and we'll talk a little bit more about that. Legal history. If someone has a legal history, it's sometimes difficult to find housing for them, or any significant behavior challenges or other barriers to placement at times. So workforce shortage, we all know, aging population, increased need for caregiver services in the home setting. The MCOs, our role is to go out, complete that needs assessment to determine the caregiver support hours that individual might need. And then the individual is offered choice on which providers they would like to use. They can use agency direct. There's a variety of agencies they can choose from. They can choose to go self-direction, where they're really the employer of that worker. And so once that is done and they choose which route they're going, there still is barriers to filling those assessed hours. So we have a lack of workers, particularly in the rural and frontier areas of the state, but it's also a challenge in the more metro areas. There just aren't enough workers for the need. Agencies report, you know, a lot of challenges, and we hear back is if the member needs 24/7 care, those are really difficult to staff, to find enough workers to meet that need. But conversely, it's also challenging to staff somebody who only needs a couple hours of support, because you're using a valuable worker to go in and, you know, travel to and provide just a couple hours of care when maybe that worker could get an 8-hour shift somewhere else. Medicaid rates, also a lot of discussion around that. They lag behind other employment options. You know, you can go work for Amazon and get $15, $18 an hour and insurance and paid time off. When you're working as a Medicaid direct service worker, the pay rate is lower. You don't get paid insurance, you don't get paid time off, so it kind of lags behind. There's a discrepancy in rates between the HCBS waivers. So you can, as a worker, you can get paid more to provide services to somebody on one waiver than you can on another waiver. And I know KDADS is working to bring those into alignment. We're also hearing that workers, just like kind of the rest of us, they want remote jobs. So if they're able to find a job where they can work from home for their own personal safety, the safety of their own families, make the same or better money, have paid insurance and paid time off, that's what they're interested in. And then fewer people working multiple jobs. So a lot of these direct service worker jobs are a second or a third job for some folks, and we're seeing less of that. So people have either kind of changed their lifestyle to be able to have fewer jobs, or they're finding a better job that supports their financial need and they no longer need to work multiple jobs. So some of the things that we're doing to try to address the shortage, we convened a work group in 2019 with multiple stakeholders and really looking at the issue, the workforce issue from end to end. I mean, it's the training, reimbursement, availability, all of that, and having those discussions. And we continue to do that and looking for solutions. One of the things that we also did is the Kansas Personal Care Directory. We have supported that since 2020 and are continuing to do so. So that is an online directory and job board where a consumer can go out and look for a worker, post a job, you know, need somebody for mom, 8 hours a day, you know, Monday through Friday or whatever, and put that out there as a job, an ad. And then the workers also then can go in and apply for those posted jobs and then connect directly to the people who are needing to hire. It's a pretty cool tool. It's not widely used when we're continuing to look at ways to increase the use of that tool. Alternative payment arrangements. You've heard all of the MCOs talk about single case agreements, and that's where we're able to offer an enhanced rate on an individualized basis for folks with really needs that are kind of extraordinary beyond what a typical person would need. We also do that for mileage reimbursement. Sometimes in the more rural and frontier areas, we might be able to find a worker, but they live 45 minutes away from the individual who needs the care. So we may offer mileage reimbursement to make that a more feasible option. And then technology solutions. There's a lot that we're looking at and trying to do around technology. And I'm going to focus on a couple of those. So the first one I want to talk about is Carebridge. And this is a partnership that we have with Carebridge, and it's a pilot, and we're continuing to expand it. But we focused on our frail elderly, physical disability, and technology-assisted waivers. And the member receives a tablet that connects them to a care team that is available to them 24/7. So the tablet is free to the member. It's delivered directly to their home, and then if they have any issues getting it, you know, started or activated, there is support for them from the Carebridge team. And in order for the member to access that care team, there's a red button. All they have to do is press the red button. They have access to their care team. And the care team includes physicians, doctors, occupational therapists, physical therapists, social workers, behavioral health clinicians. It's really a comprehensive, multidisciplinary team. So some benefits that the member receives through using this Carebridge program is, again, they have availability of a nurse or a doctor 24/7 through push of a button. And since Carebridge is actually a provider, they're contracted with United as a provider, they're able to do some treatment for the member. So they can do things like order and refill medications. I mean, how often do you, oh gosh, it's Friday at 5 and I just realized I don't have my medication. Or maybe it's, the weekend, Sunday. And so you can't, it's like, oh my gosh, how am I going to do that? They can do that for you, for the member. They can order a mobile x-ray to come to the member's home. They can order therapies like speech therapy, physical therapy, occupational therapy. They order supplies, medical equipment. They also just provide emotional supports. We have some members that just push the button because they want somebody to talk to, and they're there for that as well. And then they do some advanced care planning with the members. This is just one of the many stories that we have for this Carebridge program, and this is kind of a simple one, but it's impactful. So this is a 52-year-old male with multiple medical issues, including some depression on the behavioral health side. He completed his initial visit with Carebridge in October, and then on November 24th, which either is Thanksgiving or before Thanksgiving, but he pushed his red button with concerns about some abdominal pain. So he was triaged with the nurse who escalated it to the physician. And then the physician worked with the member and the caregiver to discuss some treatment options. They did some hydration and some medication. Followed up with him then, and he said he's feeling a lot of relief. Really appreciated Carebridge being there for them, so he didn't have to go to the emergency room. And then again in January, he called Carebridge with complaints of a cough and some congestion. We reached out, he didn't answer, but then at 3 a.m. on the 12th, he messaged the tablet that he needed to be seen immediately. So he had a visit with the Carebridge provider at 3 o'clock in the morning, was given advice and a treatment plan, and then when Carebridge followed up with him on the 13th, he was already feeling relief from his acute respiratory infection. So two kind of simple medical things that he would have ended up in the ER over, and we was able to get his care needs met during a holiday and after hours. And then they also make sure that he gets connected back with his PCP. So he is seeing his PCP more consistently now, starting in December, while continuing to be followed by Carebridge. So we're really excited about that program. I have some awesome stories like that one where we've been able to avoid ER visits, inpatient visits, and just also kind of meet the members' support needs. So I'm really excited about that program. A couple of other technology support areas that we are exploring. One is we're getting ready to kick this one off. It's a member care, we're calling it the Member Care Hub pilot. So the member would receive a Amazon Echo device. It is HIPAA compliant. It has cellular Wi-Fi, so there's no need to have internet. It is both voice and video. So it's voice activated, and then you're able to, there's video calls that occur there. So we're going to be able to connect the member with their care coordinator, so we can do more face-to-face type interaction through the video. We also are partnering with one of our brain injury waiver providers to do telehealth visits with this technology. So while this provider has been doing telehealth with some members, it's really been kind of limited to members who have the technology and whatever device that they need to be able to do that. And this kind of expands that to folks who maybe didn't have a device or the ability to participate before. And the other really cool thing about this pilot is it also will allow them to have video calls with members of their care team, including their family. So if the member wants to add their son to their care team, we can authorize that, and then they can have video calls with their son. So it reduces that isolation piece. So really like that. And were you wanting to say something? I saw you pop up.
Melody, I apologize. We have about 9 minutes left on the call. So if you could maybe wrap up in about a minute, we can let the other two MCOs also provide some details.
I will do that. I will do that real quick. So another pilot opportunity where we're looking to address loneliness and social isolation. And that one we're still in the exploratory phases. We have multiple value-added benefits that are available to our elderly population. And then the last thing I want to make sure I touch on is our dual special needs plan. So these are members who are eligible for both Medicare and Medicaid. And so the low-income elderly and under 65 disabled, and they get a lot of extra benefits. So things like $175 a month on a debit card to buy fruits, vegetables, over-the-counter items, $44,000 for dental, $400 additional vision allowance, routine foot care for our members, hearing exams. There's a meal benefit up to 42 meals for 21 days, telehealth, house calls. There's a fitness program, Fitbit, personal emergency response system. So there's a lot of extra benefits that are available to our seniors that participate in the DSNP plan. I think that was a minute. I'll stop there.
Thank you, Melody. Jennifer, would you like to share, or would you like me to share my screen?
If you could share the presentation, that would be great.
Okay.
Thank you. And I'll be quick to kind of summarize each slide so that Nan has plenty of time to present as well. What Melody was saying, I was saying, yes, we're kind of following some very similar things in terms of just how we manage members in the senior population, and particularly those members around, who want to transition from long-term care into the community. We saw just a very slight change in our transition numbers from 2020 to 2021. Certainly during that first year of the pandemic, there was an increased interest in terms of family members and members reaching out to us, curious about coming into the community and what supports were available. We did see a spike in sort of interest, and that was just related to fear around the virus, limitations around family members being able to see their members in those facility settings. So, and again, our numbers were pretty steady. And then in 2021, we did see a small increase in our actual transition numbers, but the interest was certainly there. And we were, and you can advance to the next slide. I'll talk just briefly about our program. Very similar. We have single point of contact for our facilities. We really want to try to make it easy for them to outreach Aetna, get connected with a service coordinator to work with any member who is interested in transitioning. We meet and communicate with those members frequently, and also their care teams. So we include invitations to the facility staff, family members, anybody who's important to that member. We're trying to stay connected. It's been challenging not to be able to see members during the pandemic. That has certainly limited and created some barriers for us in those discharge planning meetings, and it's just easier to connect and really help build those transition plans with members when we can see them in person. That's certainly our preference. So there's been some limitations around that, but the facility staff has been amazing to work with. We've really tried to partner with those providers and wrap around those members to build those transition plans as people are interested in coming into the community. And we can advance. So rebalancing for LTSS for us, our goal is 70%. We really want to try to, again, just have a program where we're supporting those members who want to reside in the community setting. Challenges that Melody had mentioned around workforce concerns and provider capacity. We're just really trying to work individual by individual. So it depends on what area of the state that member's living in terms of access to certain providers and how to build that network and team around them so they can successfully move into the community. We're also doing some enhanced payment arrangement with providers for those cases where we really just have to do that in order for that provider to be able to hire in a staff to support that member. So we're trying to be creative, trying to kind of work on a case-by-case basis. And I'll talk a little bit in the next slide in the next couple slides about kind of just how we're working with our task force within Aetna. So my team is the clinical team. So we do the service coordination. We're doing assessments for all of those members, all of the outreach and care planning. So we're having consistent conversations with those members kind of about what their goals are. What do they need? What do they want to do? Where do they want to move? And what does that look like for them? And then the second piece of that is really working closely with our network team. We want to make sure that we're, exploring all of the network providers that we have access to, that we're actually reaching out to them, communicating about the barriers and challenges that they're having and what they need to be able to support our members. So we're having weekly meetings, and we're still doing that just to try to, again, identify those barriers, figure out what those providers need so that we can help support moving those members into the community. And part of what we're doing too is once a member is in the community, we want to make sure we're supporting them so that there's not a step back where they have to go back into the facility. So we do enhanced touch points for members when they're in the community. We're looking at service utilization for all of our seniors that are living in the community with supports. We're making sure that the services that we've assessed them to need are actually being provided. So again, during our touch points, we're doing a lot of conversations just around, hey, is your caregiver coming out? Are your meals being delivered? Just to make sure that we're identifying any concerns that they might have. And we can wrap. Thank you. There's 3 minutes left. Sorry.
I think you're talking on mute, Hina. Or it was
Look
me.
at that. You're right. No, it was me. So Nan, did you have any comments that you wanted to share as well? I apologize for only giving you a couple minutes.
You know what? It's absolutely fine. I appreciate the opportunity to come back and chat a little bit more. I did just a couple weeks ago talk about our direct care workforce, and I love being third because I can say, yes, as United said, I do oversee our community transition liaisons as well as our nursing facility repatriation team here at Sunflower, and all the same things. We did see an increase. Our increase hasn't gone back down quite yet with 2021. So we are still seeing an increased amount of individuals who are identifying wanting to transition back into community settings. Same exact barriers, I'm sure they're not exact, but very similar barriers. The lack of in-person visits, really, relying on our community, our transition coordination providers in the community to do those face-to-face interactions while we were in that, not able to do those, as well as the facilities were not looking at us coming in. I shared last time about our pilot in regards to social isolation. And I think the other part Jennifer mentioned, I think Melody did as well, that the Appendix K flexibilities and that flexibility on utilization of family caregivers, as well as some continued flexibility and increasing the leveling of service rates. Definitely a situation with our direct care providers in regards to that professionalization. The fact that they do not receive paid time off, so our direct care workforce crisis that was in play long before the pandemic still is there. We also are looking for innovation, both across technology, and one of the things we're looking at right now with Appendix K is, are there other things in that assistive technology arena that might be of assistance that aren't necessarily identified now, but with Appendix K, we have a little more flexibility. Things similar to grocery delivery. So something that we've seen grow across the board, but is that something we can look at for the members that we're supporting?
Thank you. And we are right at 10:30, but if someone has like an immediate question, I will risk not following a meeting commitment if you guys are on board. All right, well, I think you guys gave them a lot of reports to review, some good information today. And so come back with any questions next time or in between the meetings so we could send them to the MCO representatives as needed. Next time you will finish up some presentations, one from Tanya Dorf-Bruner on oral health with Oral Health Kansas. And then also take a look at the data that was sent, your data request from KDADS. See if you have any questions from that as well. I don't know if you had a chance to look at all of the reports, but there was one that gave kind of this nice geographic view of kind of where the adult day centers are. It was in one of the MCO reports. I put it out, I think it was like slide 19. So take a look at that for sure. And we will put recommendations together. So come ready to Google Jamboard, sorry, next time as well to develop recommendations. I do want to ask one question. I noticed that some people had meetings for April 1st on their calendar and some didn't. Does everyone have April 1st on their calendar for this working group? And if yes, I'm going to move funding and implementation, that conversation of the Kansas Senior Care Act, to maybe on April 1st. And you can hear from 3 experts then, Leslie Anderson, based on their availability, also Sean Marshall from KLRD, and Jesse Pringle from the Revisor's Office. And I know you also wanted to hear from Ernest Cutzley, ARP, on the National Scorecard. So if everyone's available April 1st, then I will definitely put that on the calendar. Your next meeting, though, to put recommendations together for Senior Day Services is March 25th, though. So because you have 4 topics, you have one extra meeting kind of in there, and that's why. So if everyone's got that, then I will work with our speakers to see if I can move the March 25th speakers to April 1st and have you guys hear from the rest of the experts on March 25th and develop recommendations that day. All right, well, I apologize for keeping you over 3 minutes. Again, any questions for the MCOs, please send to me. Any additional data requests, let me know, and I will be sure to share any further information I receive, some reports and data that you requested during this meeting to be sent back to you in advance of your meeting on March 25th. All right, I will see you then. Thank you.